today vaccination has become a very hot topic because of this pandemic. But my scope in today's lecture will be a general overview in vaccination in childhood. So the objectives for today's session will be, first we will see what are the types of vaccines which are available for children in current practice. Then we will learn about the extended program of immunization schedule which is available in Sri Lanka, and also the vaccines outside the schedule which are available in the private sector, which the patients have access to. And then we'll talk about a little bit about vaccination procedure. Then what are the special circumstances where vaccination has to be done, and what are the special precautions you need to take under these circumstances. And finally, what to do in adverse events following vaccination. So before we go to the types of vaccination, what is a vaccine? A vaccine is a biological preparation. It's a biological preparation that provides active acquired immunity. So these words highlighted are important. It's a biological preparation that provides active acquired immunity to a particular disease by stimulating the body's immune system to recognize this agent as a foreign one, destroy it, and then keep a record of it for future use. So it's a biological preparation which provides active acquired immunity by recognizing an agent, destroying it, and keeping a record of it. So there are about four types, major types of vaccines. The first type is whole pathogen vaccine. That means the whole bacterium or whole virus is included in the vaccine. And it can be either a live attenuated or partially killed vaccine, or it's a completely killed vaccine, inactivated vaccine. We will discuss about this in the slides which are in my later slides. Then we have subunit vaccines. There you don't use the whole pathogen. Whole cell is not used. Only a subunit of the agent is used. And vaccines which come under that includes recombinant protein vaccines, toxoids, conjugate vaccines, virus-like particles, we call them VLP, and outer membrane vesicles or OMV. Then you have the latest nucleic acid vaccines, RNA and DNA vaccines, and finally viral vectored vaccines, which can be divided as non-replicating viral vectored vaccines and replicating viral vectored vaccines. So let us see, we'll take one by one and learn about these types. So first, whole cell, where the whole pathogen is used, and the first type is live attenuated. Live attenuated means the organism is alive, the pathogen is alive, it can replicate inside the body, but it has been attenuated so that it will not produce any disease. So it will stimulate immunity, but will not produce the disease. And this type of vaccines, the advantage is they have strong immunity and they are long lasting. Therefore, they usually require only one dose or maximum 2 doses. So the common examples are MMR and live Japanese encephalitis. But oral live vaccines may need more boosters, such as the polio vaccine, which needs about 5 administrations in a child's lifetime. The only problem is because it's a live attenuated in immunodeficiency states. If a child has an immunodeficiency, it is contraindicated because this live attenuated vaccine in an immunodeficiency child can cause the disease. Then the second type is inactivated or the killed vaccine. Again, it produces strong immunity, but because it has been inactivated, it can't replicate inside the host. Therefore, the vaccine immunity is strong, but it is short lasting. And the result is we need repeated dosing, right? And the examples are rabies vaccine, inactivated polio, and hepatitis A. So these vaccines, they use the whole cell but killed. Therefore, you need repeated boosting. Then we come across subunit vaccine, where part of the cell is used. And one common vaccine is the recombinant protein vaccines. what happens is a small piece of DNA from a pathogen is inserted to a DNA of a harmless yeast, okay, and allowed to replicate. So it's not the pathogen which is replicating, but it's a harmless yeast. And these yeast cells produce the antigen of the pathogen which we need, which is then purified and used as a vaccine. So the common examples are hepatitis B, meningococcal B, and human papilloma virus, some types of human papilloma virus vaccine. So a small piece of DNA from a pathogen is included in a harmless yeast, which replicates, and the antigen of the pathogen is purified and used as a vaccine. Then the second one is toxoid. So like the inactivated whole cell vaccine, here the toxin which is produced by a pathogen is inactivated. So once a toxin is inactivated, we call it a toxoid. And this also need repeated dosing. The three common toxoids we use are diphtheria, pertussis, and tetanus. The third type is conjugated polysaccharide subunit vaccines. Now, some vaccines are made using the polysaccharide part of the capsule. And children below 2 years can't produce strong immunity against the polysaccharide subunits. Okay? Children below 2 years can't produce strong immunity against polysaccharides. Therefore, these polysaccharides are conjugated or combined to a protein, because children under 2 years identify proteins better than polysaccharides. So therefore, these are called protein conjugated polysaccharide subunits. And the common example is pneumococcal vaccine, meningococcal vaccine. There are polysaccharide pneumococcal vaccine for adults, but here I am talking about conjugated pneumococcal and conjugated meningococcal vaccine. Then subunit vaccines continued. You have another type of vaccine using virus-like particles. We call them VLP. These virus-like particles either occur naturally or they can be commercially manufactured. And these particles are completely harmless, but they are immunogenic. So you can use to produce antigens either of one or multiple pathogens. If they are manufactured, you can manufacture a virus-like particles to carry either one or multiple pathogen antigens of one or multiple pathogens. Some hepatitis B vaccines and some types of human papilloma viruses vaccines are manufactured using virus-like particles. Then outer membrane vesicles. Some companies used outer membrane vesicles to produce vaccines. And what are outer membrane vesicles? Some pathogens like meningococcal agent, they have vesicles in the outer membrane. Okay, so they have small vesicles in the outer membrane which carries surface antigens. So they are immunogenic, but they are harmless. Without the full cell, these vesicles are completely harmless. So what some companies do is they extract the vesicles and include them in a vaccine. And some type of meningococcal B vaccines are made using outer membrane vesicles. The third type of vaccine is nucleic acid vaccines. And nucleic acid vaccines, these provide the genetic instructions to the host cells to produce antigens and then immunity. In other vaccines, we introduce the antigen to the host. Here, we don't introduce the antigen. We provide the genetic instructions to the host cell, and the host cell will produce the antigens which are needed for immunity. So it's a more advanced procedure. So the two types of genetic instructions we can provide is through RNA vaccines and DNA vaccines. So in RNA vaccines, a messenger RNA which is covered with a lipid layer for the protection of this RNA. So you use a lipid layer for the protection of the RNA, and this RNA is introduced to the host. So this is the RNA which will be carrying the genetic instructions. And the host using the messenger RNA will produce the immunity. After a while, the mRNA will be degraded. So the current Pfizer, BioNTech, and Moderna COVID-19 vaccines are produced using this technology. Another technology uses DNA vaccines. And DNA particles or the DNA vaccine, they are much more stronger than messenger RNA. So they don't need a protection layer. Okay, they will go into the host and stimulate mRNA production. So the host will produce mRNA. Here the vaccine brings mRNA or messenger RNA. Here the host will produce messenger RNA using the DNA particles in the vaccine. And then it will produce antigens which will cause immunity. At the moment, for humans, these vaccines are not manufactured yet. They are still at animal study stage. But in the near future, we will get these DNA vaccines. Then the final one is the viral vectored vaccines. Here, they use a harmless virus to deliver the genetic code of a target vaccine antigen. And this virus is completely harmless. It will not cause any pathogenic problem in the host, but it will deliver the genetic code needed for producing target antigens. These are very cheap than most subunit vaccines and nucleic acid vaccines. So in the future, viral vector vaccines might come as a popular agent because of the cost-effective nature. And there are two types, the replicating viruses and non-replicating viruses. So if it's a replicating viral vectored vaccine, it's like a wholesale attenuated vaccine, right? Because it is live and it can replicate inside the host and it is completely harmless. The wholesale vaccines, wholesale attenuated vaccines can become harmful in immunodeficient children, but these are, even in immunodeficient children, harmless. And a single dose may be effective because the viruses can continue to replicate inside the host, producing the immunity. And some of the Ebola vaccines were produced using this technology. And then there are non-replicating viral vectored vaccines where the virus is inactivated and then introduced to the body. So the the harmless virus which delivers the genetic code is inactivated. Because it is inactivated, it will not cause long-lasting immunity. It will need repeated boosting. And the Oxford AstraZeneca vaccine, COVID-19 vaccine, which most of us received in the past, was produced in December 2020 using this technology. So it's called ChAd-Ox because it was produced using a chimpanzee adenovirus as the vector. Okay, so the vector was a chimpanzee adenovirus and it was inactivated so that it will not cause adenoviral infection. And it was produced in Oxford, so ChAd-Ox was given as the name. And before we learn about the vaccination procedure, we need to learn about some special terms. So monovalent and polyvalent. What do you mean by monovalent and polyvalent? Monovalent is protection for single strain of a particular organism. Right? So monovalent vaccines protect against a single strain of a particular organism. When you say a polyvalent vaccine, that means it protects multiple strains of the same organism, or it can protect several organisms, like combined vaccines. So when we say pneumococcal 23-valent vaccine, it means 23 strains of pneumococcal is protected. But in MMR, a combined vaccine, it's also a polyvalent vaccine, but it is not protecting the strains, but protecting several different organisms. Then what are adjuvants and what are diluents? Adjuvant is a substance used in the vaccine preparation to improve the potency of the vaccine. Right? The common adjuvant used is aluminum phosphate and it will increase the potency of the vaccine. A diluent, on the other hand, is a solution specifically manufactured to reconstitute a particular vaccine which comes in a powder form. Okay, so when you reconstitute it using a diluent, the powder form vaccine will become an injectable liquid. Now we will concentrate on the extended program of immunization in Sri Lanka. And these are the vaccines which come under the program. BCG vaccine, pentavalent vaccine, oral poliovirus vaccine, inactivated poliovirus vaccine, MMR or measles, mumps, rubella. Then the DPT, diphtheria, pertussis and tetanus. DT, diphtheria, tetanus. HPV or human papilloma virus. Simple A, capital T, simple D, adult, tetanus and diphtheria vaccine. And finally, live JE vaccine, live Japanese encephalitis vaccine. So if you go to the epidemiology unit or family health bureau, you will come across this schedule. So we start BCG at soon after birth, preferably within the 24 hours. And then at 2 months, 4 months and 6 months, we give OPV and pentavalent vaccine. But in second month and fourth month, an additional fractionated intradermal polio vaccine is given. And at 9 months, we give the first MMR dose. At 3 years, we repeat the second MMR dose. And meanwhile, at 12 months, after completion of 12 months, single live Japanese encephalitis vaccine is given. And at 18 months, we give the OPV and DTP fourth dose. During school age, at 5 years, OPV and DT. 10 years for girls, HPV first dose and HPV second dose with a gap of 6 months. And at 11 years, you give adult tetanus diphtheria vaccine. Okay. If a female in the childbearing age, that is 15 to 44 years, has missed the MMR vaccines, we can give a MMR vaccine to all females between 15 and 44 years before they become pregnant. Right. So some special notes on the common vaccines which are available in our schedule. Now there have been some recent changes in polio vaccination program. Earlier schedule, we used a trivalent oral polio vaccine. So trivalent oral polio vaccine covered 3 types of polio virus: polio 1, 2 and 3. Advantages is very good for herd immunity because the polio virus which is given as a vaccine is excreted via stools and it can reach the other unvaccinated children and produce immunity. But the disadvantage, sorry, there's a spelling mistake. The disadvantage was the type 2 vaccine. So the type 2 particle of oral polio, trivalent oral polio, has been associated with vaccine associated poliomyelitis. Okay. The type 2 trivalent is type 1, 2, 3. The type 2 particle is associated with vaccine associated poliomyelitis. Therefore, the current schedule uses a bivalent oral polio vaccine which covers only type 1 and 3. So type 2 is not covered in the oral polio program. Therefore, the vaccine associated poliomyelitis incidence has come down. But we need to protect the child with type 2. So together with the bivalent oral polio vaccine, we give an inactivated intradermal polio vaccine which covers mainly type 2. But it can also increase the immunity to type 1 and 3 as well. So bivalent oral polio covers mainly 1 and 3. Inactivated intradermal polio, which is given as 2 doses at 2 and 4 months, covers mainly type 2, but it can cover type 1 and 3 as well. And BCG vaccine, remember, we can give maximum of 2 doses for an absent BCG scar, including the first dose given after birth. Normally, if a scar is absent, we give the second dose between 6 months and 5 years. Before 6 months, you should not give a second BCG vaccine just because there is no scar. You have to wait until 6 months have gone by. If you are administering the BCG vaccine for a child above 1 year, the dose is 0.1, not 0.05. This is the dose given at birth. But if you are giving the BCG to a child more than 1 year of age, you have to double the dose. MMR, previous measles, mumps-like illness, is not a contraindication for the vaccine. Now, this is a very common situation. Some children develop measles-like illnesses before the vaccine, and there is a lot of confusion whether or not to give the vaccine. But previous illnesses, which looks like measles or mumps, is not a contraindication for the vaccine. You have to complete the vaccination program. Then vaccines outside the EPI schedule. So what are the vaccines outside the EPI schedule, which either the hospital can purchase locally or the parents of a child who request this can purchase it in the private sector. So the common vaccine which is used is hexavalent vaccine. So hexavalent vaccine is given instead of the pentavalent vaccine and oral polio. The hexavalent vaccine contains diphtheria, acellular pertussis. In the pentavalent, you have whole cell pertussis, but here we are using acellular pertussis. So the reactions which is associated with pertussis is minimal with this vaccine. It has tetanus, Haemophilus influenza type B, hepatitis B, and inactivated polio virus. So when you are giving a hexavalent vaccine, there is no real need for oral polio vaccination because the inactivated polio virus here covers type 1, 2, and 3. But if you are targeting herd immunity, pentavalent vaccine plus oral polio is much better compared to the hexavalent vaccine if your primary target is to achieve herd immunity. There are two brands, the Infanrix Hexa, which is produced by GlaxoSmithKline, and Hexasim, which is produced by the Sanofi Pasteur Corporation. Infanrix Hexa comes as a lyophilized powder plus a liquid component. So we need to, before administering, it has to be reconstituted. But the Hexasim comes as a direct liquid suspension in a pre-filled syringe. Then varicella vaccine, okay, vaccine against chickenpox is available. The dosing schedule is, if you are giving to a child between 1 to 6 years, it has to be given above 1 year. So if the child is 1 to 6 years old, 2 doses are given with a minimum gap of 3 months. For child 7 to 12 years, again 2 doses are given with a gap of 3 months, but in an emergency situation, you can give with a minimum gap of 4 weeks. So before 6 years, the minimum gap is 3 months, but after 6 years, minimum gap is 4 weeks. If you are 13 years and above, 2 doses are given with a gap of 4 to 8 weeks. Then another vaccine which is available is pneumococcal vaccine. It's a conjugated vaccine. In developed countries, there is a 13-valent variety available, but in Sri Lanka, we have the 10-valent vaccine. Okay? And it is given as 4 doses. So given at 2, 4, 6 months and a booster dose at 12 to 15 months. But if a child misses the vaccine during the first 6 months, it can be started at 6 months as a 3-dose schedule. If the child comes for vaccination after 1 year, then 2 doses 2 months apart is enough with a booster dose given between 2 to 5 years. After 5 years, this vaccine is only indicated if there are certain medical conditions. I want to make one note about this pneumococcal vaccine. The general public commonly know this vaccine as the pneumonia vaccine. Right? 90% of parents who come to get this vaccine, who has pneumonia vaccine, which is the wrong terminology, because we as health professionals should educate them that this is only for pneumococcal pneumonia. It will not cover all other pneumonias, because most parents think that by giving the pneumococcal vaccine, all pneumonias are covered. So this misconception has to be broken, right? Because they are paying for the vaccine and they are giving it for their own children, and they should be aware of the real indication and real coverage of this vaccine. Right. Then we come to the rotavirus vaccine, which is given as 2 to 3 doses. It depends on the type of vaccine. So there's a vaccine called Rotarex, which needs mainly 2 doses at 2 and 4 months. But the Rotatec variety, it's better to give as a 3-dose schedule given at 2, 4, 6 months. This covers against the rotavirus infection. Again, there is a misconception or misunderstanding in the community, because this is known as the diarrhea vaccine, which is completely wrong. Rotavirus does not covers against every diarrheal infection. So we as health workers has to educate the parents that this vaccine only covers rotavirus diarrheal infection, not other diarrhea. So even after getting this vaccine, they have to maintain proper hygiene when they are feeding their babies to prevent other viral diarrheas. There are some other vaccines available outside the schedule. The hepatitis A vaccine, hepatitis A and B combined vaccine, typhoid vaccine, yellow fever vaccine, and also influenza vaccine, which is given in other countries during the winter season. But in Sri Lanka, we don't routinely give it, but on request, it is available. So now we come to the vaccination procedure. Most of the vaccines nowadays are given using the auto-disabled syringe rather than using same syringe for different children. The auto-disabled syringe avoids contamination of other children, because once you use this, it will be auto-disabled, right? So single syringe for single patient. And then in most of the vials, there is a vaccine vial indicator, which we need to be aware of. This vaccine vial indicator will tell us whether the vaccine is suitable for use or not. The indicator will have a dark circle with a square which has a lighter color compared to the dark circle. So if the square is lighter than the background dark circle, it can be used. Now you can see these two squares are lighter than the background, but this square is much more darker than the first vaccine. So if you have two vials like this, you have to use this vial first and later on this vial, because this has better shelf life. If the square, the color of the square is equal to the background or darker than the background, then we should not use. It should be discarded even if the expiry date is still has not been surpassed yet, right? So even if the expiry date has not been surpassed, still if the indicator is dark or equal in color to the background, you have to discard it. Then what are the routes of administration? The preferred route by children is these two routes, the oral route and the nasal route. Both have good absorption qualities. The nasal route is much more better than the oral route, more tolerated than the oral route. But unfortunately, only few vaccines are available in this route. Most of the vaccines we have are injectable vaccines. And the three routes which are available is intradermal, which is given with a needle with 15-degree angle to the skin, and the needle should only pierce the dermis, should not reach the subcutaneous layer. Then subcutaneous route, where you are inserting a needle with a 45-degree angle and reaching the subcutaneous layer. And the last route is intramuscular, where you are inserting the needle at 90 degrees angle to the skin, reaching the inner muscle layers. So before a vaccination, we need to rule out absolute contraindications. And in vaccination, there are very few absolute contraindications. The two most common is if there is an anaphylaxis reported with the previous same type of vaccine, then that vaccine should be avoided. And live vaccines are avoided in severe immunodeficiency states. What are the situations where you might need to postpone the vaccine? So postpone is not a contraindication. We are just postponing until the child recovers from the condition which is under scrutiny. So one such situation is a febrile infection with a fever more than 38.5. Mild fever like 37.2 or 3 is not an indication to postpone the vaccine. You can give it. But if the fever is more than 38.5, better to postpone the vaccine. And it can be given once the child becomes afebrile. Even while the child is on antibiotics, most vaccines can be given. Live vaccines are given less than 4 weeks before. Okay. So if there's a live vaccine which has to be given less than 4 weeks before, you need to delay it until a 4-week gap is present. There should be no gap needed between live and inactivated vaccines, right? But you need minimum 4 weeks between two live vaccines. But if you are giving the two live vaccines on the same day, if you are giving it on the same day, then you can give not only two, as many vaccines you can, but using different sites. So multiple live injectable vaccines can be given on the same day using different sites. If there's any reported significant allergic reaction in the past, it's not anaphylaxis, but a significant allergic reaction, you don't still need to postpone, but vaccination should be done under close observation or inward setting. If you do not have inward setting, you can postpone the vaccine until an inward setting is available. If there's a febrile or afebrile seizure, then it's better to postpone the live Japanese encephalitis vaccine for a minimum interval of 1 year. But this is only for the live Japanese encephalitis vaccine. No need to postpone the other vaccines. There are false contraindications. Many doctors, nurses, or midwives sometimes have false contraindications. So these are the contraindications which are false, which do not need postponement or avoidance of vaccines. Mild illness without fever, family history of any adverse events following immunization, past history of convulsions, not for JE but for other vaccines, antibiotics, treatment with locally acting steroids like topical steroids, asthma, eczema, and atopy, previous pertussis-like illness, measles, rubella, which I have mentioned before, prematurity, neonatal jaundice, contact with an infectious disease, child's mother is pregnant. So there's a lot, right? There's a big exhausting list where in the society unnecessarily vaccine have been either postponed or avoided. This list is available in the Immunization Handbook of Sri Lanka. Then vaccination during special situations. So there are special situations which I will talk about. There are 4 special situations: prematurity and low birth weight, immunodeficiency states or child on steroids, blood transfusion and post-immunoglobulin therapy, child with a clotting disorder. So prematurity and low birth weight, if the child is medically stable, the usual schedule can be used, which is similar for term babies. You don't need to correct the gestational age. You can give at the actual age, right? You don't need to postpone any vaccine. You can use the same schedule. Pneumococcal vaccine and rotavirus can be routinely given as it happens in some countries. Hepatitis B, in some countries, an additional dose at 1 year is recommended, especially if the child is less than 32 weeks and having a birth weight less than 2000 grams, sorry. In some countries, for premature and low birth weight babies, influenza is recommended yearly. If the child has an immunodeficiency state or child on steroids, live vaccines are avoided in severe immunodeficiency states. In mild immunodeficiency states, some live vaccines like MMR can be given under close medical supervision. Inactivated vaccines are safe but may need extra doses compared to a child with normal immunity. Household contacts can receive live vaccines. If there's a child with immunodeficiency and the household contacts who are immunocompetent can receive the normal live vaccines, there is no contraindication for them. It's better because then the household contacts will be protected against the disease, and by that way you can indirectly protect the immunodeficient child. So child on steroids. If a child is on steroids at a dose of less than 1 milligram per kg per day for a duration less than 30 days, you can vaccinate anytime during this therapy. If a child is on less than 2 milligram per kg per day and the duration is only less than 14 days, again, you can give anytime during therapy. If the same dose is given but for more than 14 days, like 14 to 20 days, then you will have to immunize 1 month before starting corticosteroids. It's better if you can immunize before the therapy or at least 1 month after stopping steroids. Right? Alternatively, persons may be able to receive live vaccines at any time during therapy, but only after seeking expert advice. So it's better, rather than vaccinating during this period, either vaccinate 1 month before starting the therapy or 1 month after stopping the therapy. If a child is on high dose steroid, more than 2 milligram per kg per day, but less than 14 days duration, then again better to immunize 1 month before or anytime after stopping the corticosteroids. But if the same dose is given for more than 14 days, then you have to again immunize 1 month before starting corticosteroids or 1 month after stopping corticosteroids. In some countries, for high dose steroids, it is recommended to give live vaccines only after 3 months. Okay, so from country to country, it will change. So some countries allows only 1 month gap, but in other countries they expect a 3 month gap after receiving high dose steroids for more than 14 days. So what about solid organ transplant? If possible, you can give all the vaccines before the transplant. And live vaccines should be given at least 1 month before the transplant. But if you need to give vaccines post-transplant, after the transplant, then you can use inactivated vaccines 3 to 6 months after transplant. In countries like Australia and USA, they prefer a longer duration of vaccine-free interval like 6 months. But in countries like India, a 3 month gap is more than enough. Live vaccines after post-transplant is contraindicated. If the child has to travel after transplant, vaccines like typhoid and hepatitis A vaccines can be given as long as they are inactivated vaccines. An annual influenza vaccine is indicated for any child who has undergone solid organ transplant. What about hematopoietic stem cell transplant or HSCT? Again, live vaccines are contraindicated for 24 months following the transplant. Okay, for 24 months. So that means for 2 years post-transplant, live vaccines are contraindicated. This duration can be extended if there's ongoing graft versus host disease or ongoing significant immunosuppressive therapy. Right? Inactivated vaccines, now regardless of the previous vaccine status, once the child has undergone hematopoietic stem cells transplant, we have to forget the vaccines which has been given before. You need to restart the course. So all inactivated vaccines are given regardless of the previous vaccine states, and this should be given according to a new schedule. This will be commenced after 6 months, but again in developing countries like India, even a 3 month gap is enough. Where the disease load is high, they will not recommend a 6 month gap, but they will start the vaccination by about 3 months. So this is the new schedule which you can use after hematopoietic stem cells transplant. So vaccines DTaP, HIP and Hep B and IPP, or the hexavalent vaccine, because it's an inactivated vaccine, can be given first dose 6 months after transplant, second dose 8 months, third dose 12 months later. So a 3-dose schedule. Right? Human papilloma virus, 3-dose schedule, but starting at 8 months. Influenza, you can give the first dose at 6 months and then yearly. Meningococcal and pneumococcal vaccine, again 3-dose schedule, 6, 8, 12 months post-transplant. MMR and varicella vaccine is not given for the first 24 months after transplant, but after 24 months, if the child is not having GVHD or not on any immunosuppressant therapy, then they can receive the live vaccines after 24 months. Pregnant mothers on immunosuppressive drugs, especially DMARDs, disease-modifying anti-rheumatoid drugs, if they receive the drug during the third trimester, you have to avoid live vaccine for the first 6 months of life. And these live vaccines include BCG, rotavirus, and oral polio. If a mother in her pregnancy is tested positive for hepatitis B, what are we going to do for the neonate? And first we need to see whether it's a high risk neonate or a low risk neonate. If the mother is HBs antigen positive and HBe antigen positive, that's a high risk baby. If a mother is HBs antigen positive, HBe antigen and anti-HBe antibody both negative, still it's a high risk pregnancy. If a mother is HBs antigen positive and the HBe status unknown, still it's better to take as a high risk neonate. If a mother is antigen S positive, but she is also positive for anti-HBe antibody, then it's a low risk neonate. If it's a high risk neonate, the neonate should receive hepatitis B immunoglobulin within 12 hours of birth, or at least by 48 hours. And the hepatitis B immunization should start on first day of life. But if you can't get access to the hepatitis B vaccine, it has to be started at least before day 7. Ideally on first day, but at least before day 7. For the low risk group, only the vaccine is needed. No need to give the immunoglobulin. So what's the schedule? In some countries, a 3-dose schedule is given for the vaccine. 0, that means at birth, 1 month, 6 months. But in some countries like Australia, they use a 4-dose schedule, 0, 2, 4, and 6 months. After the child turns 12 to 15 months, it's better to check the hepatitis B surface antigen and antibody status, right? To see whether the child has seroconverted or not. If the child has not seroconverted, you might need additional vaccine doses. Vaccination following special drugs or blood products. Now, if a child has received IV immunoglobulins and if he is awaiting live vaccines such as MMR and varicella, okay, then depending on the country's guidelines, it will be delayed. The delay should be minimum 6 months according to Japanese schedule. But in some European countries and National Institute of Health, they recommend 8 months. The Americans, they go for a prolonged period of 11 months gap. Okay, so depending on the country's schedule and their guidelines, the gap or delay will vary, but minimum gap is 6 months. But for oral live vaccines like polio and BCG vaccines, no gap is needed. So you have given immunoglobulins, but the child is awaiting BCG or oral live vaccines like polio, gap is not needed. If blood products are given, like packed cell transfuse or platelets, what is the gap? If washed red cells are given, no gap is needed. If packed red blood cells or whole bloods are given, you have to have a 3 to 6 months gap. And if platelets or plasma are used, again 3 to 7 months gap. In many Asian countries like India and Sri Lanka, we recommend the shorter gap, 3-month gap. But in CDC, Center for Disease Control, they recommend a longer gap, like 6 or 7 months after blood product administration. Then vaccination in children with bleeding disorders. Best thing is to use subcutaneous route as much as possible using a fine gauge needle. 23 or smaller is better. And rather than rubbing after the injection, it's better to apply steady pressure for minimum 1 to 2 minutes. If a child is on regular clotting factor replacement like prophylaxis, then you can time the vaccination during such a transfusion. Then we come to the final part of our lecture. What are the adverse events following immunization? What are the adverse events following immunization? There are vaccine product related reactions. Okay, so adverse events following immunization means any unwanted effect. Okay, any unwanted event following immunization. So there are 6 types of adverse events following immunization. First type is vaccine product related reaction. That means the reaction is directly related to the vaccine. Common example is limb swelling, which is seen after DPT vaccination. Right? After DPT vaccination, a lot of children come with a limb swelling, not cellulitis, purely swelling of the limb. And this is a direct vaccine related reaction. Then another type of reaction is called vaccine quality defect related reaction. Vaccine quality. So there is some quality defect during manufacturing process. For example, a vaccine which has to be inactivated completely has been inactivated incompletely. Okay. Therefore, the disease which should not have been caused by the inactive vaccine has been reported to occur when a certain batch of vaccine has been given to children. So this is a quality defect. Right? Then immunization error related events, earlier known as program errors. That means whenever the vaccine is produced, transported, stored or administered, there is an error occurring, mainly because of either inexperience of the vaccine administrator or inexperience of the handler, or when the administrating person is careless. Right? For example, if you do not use proper aseptic practices during vaccination, you can get a vaccine site sepsis. So this has nothing to do with the vaccine. It is mainly because of a immunization related error. Sometimes wrong vaccine can be given, or intramuscular vaccine can be given subcutaneously, or intradermal accidentally given as a subcutaneous vaccine. They all come under program errors. Vaccines given with expired vaccines given, they also come under these program errors. So most of the events are usually due to program errors. Then there are coincidental events. For example, a child may be having an upper respiratory tract infection and fever might come after vaccination, and the parent might misunderstand thinking that the fever was due to the vaccination, but it was a complete coincidence where the child already had an upper respiratory tract infection during vaccination. Then anxiety related events, commonly due to the fear of vaccination or fear of needles, and the common example is syncope. And finally, there can be unexplained events which does not come under any of these categories. So whenever you find adverse events following immunization, you have to report it to the local authority, and there is a AEF5, adverse events following immunization form, to be filled. Right? So any event, whether they are directly related to the vaccine or not, it's better to report. So finally, we come to the take-home message. We come to the end of my presentation. So the take-home message is vaccines save many lives worldwide, and there are no perfect vaccines. Right? There are no perfect vaccines. So there are some known adverse effects or precautions to be aware of. So you have to, as a practitioner, you have to be aware regarding precautions, adverse events, and special circumstances. But absolute contraindications are very few related to vaccines. So therefore, our ultimate goal is not to find reasons to delay or avoid vaccines, but to find alternatives to somehow complete the vaccine course. Because in our current setup, there are so many excuses given to delay or avoid vaccines, but that should not be our ultimate goal. Our ultimate goal is to find either alternatives or different ways to somehow complete a vaccine course. Thank you.